What does it really look like working in an ER? Is it really like the HBO drama The Pit? Today, we're going beyond the sirens, the codes, and the TV drama and showing the humanity, the grit, and the everyday reality inside the emergency department. I'm Dr. J. Rutland, and this is The Health Exchange. Joining me today is my boy and ER physician, Dr. Italo Brown. Together, we're separating ER myths from reality with someone who's seen it all firsthand. Let's get into it. Italo.
What's happening?
Dr. Brown. We've known each other for a while.
Yeah.
It's been a while. We grew up in the same neighborhood in Sacramento, and we didn't really know each other.
One of the craziest things
One
to
of
me.
Craziest things, right? In Greenhaven. What drew you into ER? Like, what drew you into emergency medicine? When did you first start thinking, like, I'm going to do that?
It had to be my first set of rotations in medical school. So I went to Meharry Medical College. We have a variety of different exposures to medicine. And I remember this was the first thing that happened where I went to all the rotations and I didn't get tired, right? I was like, I loved OB. I loved going to peds, surgery. I said, I could do all of this stuff. Internal medicine really struck my fancy. But I got on an ER shift, 12 hours went by like nothing. And I said, I still want more. And I saw so much pathology that it just drew me into the specialty.
Is there a patient story that stuck with you?
Yeah, actually, an incarcerated patient. He came in, and interesting when you deal with vulnerable populations, right? There's this thought that they may not receive the care that they should. And then also like all of these other social circumstances. And this guy, they were just telling him at the jail, he's having growing pain, like take Tylenol, take Motrin. And we look down there and he's got Fournier's gangrene. So I just remember like, wow, this dude can die. And we caught this. Even though this is a person who normally would get overlooked by society, no matter what he did, he still deserves a standard of care. And so I think that is what stuck with me.
Explain to the audience what Fournier's gangrene is.
It's a fancy French word. I learned how to say Fournier because of him and Evan Fournier, who plays back. Right.
I played for the Magic.
Right.
Yeah.
But it's essentially like a soft tissue infection that can spread really rapidly. When people think of flesh-eating bacteria or neck fasciitis, it's in a specific region, the groin, and it can lead to very bad outcomes really quickly.
What is your general patient care philosophy?
I believe that patients come into the emergency department for one of a couple of reasons. One, they have nowhere else to go. Two, this is the worst day of their life. And three, they really have a secondary concern, something that might not be 100% medical, but could still be addressed and help improve their lives. And so I approach every day like, these are the patients that I need to see and treat and meet them where they're at. And as physicians, we have to be able to like open ourselves to that reality every single time we walk through the doors of a hospital.
When you're in the emergency room, I want to go through a day in the life of Italo Brown in the ER. All right,
let's get into it.
Let's take me through a typical ER shift. Like, walk me through it. What are you doing on the way in? Normally, you're recording yourself as you're walking in. Like, I see all that. I seen it. But like, what's going on in your head? You're walking to work. You're getting into work. Take me through that shift. Take me through that day.
As I walk through the door, I'm usually quickly saying a prayer. And the prayer is very simple. I want clarity. I want to make sure that my team is safe. I want to make sure that the patients get the best of me, and I want to limit as many mistakes as I possibly can. I just ask that right off the bat. Then I get through the thresholds. I'm usually listening to music, so it's something that's hip-hop related, maybe some trap music, because I got to get hype. It's like I'm going into a game. Wipe down the area, and then I start looking at the board. Most of the time, it's any variety of complaints, anything from headache to person amputated their finger on accident, collapse. And so I start now pulling all of this stuff to memory. And as the calls come in, the ambulances ride in, the notifications happen, it's always a matter of maintaining my personal homeostasis, like trying to be as balanced as possible, and then just thinking through problems one after another. The cool things are like, oh, you're in the middle of your shift, you get a call after eating some food, somebody's coming in and got shot in the face, and now you're like, all right, we're back to it. Thinking about airway issues, thinking about what could go wrong. But then you also have a patient in like room 12 who's about to go, haywire because he's not getting the attention he deserves, and is going to threaten the staff members. And then over in 4, you got this pregnant woman whose blood pressure is constantly going up to 140. You're worried that she's going to be in preeclampsia. And then over in 16, you got this patient who just syncopized in the bathroom and struck their head on the wall. So all of this is happening at the same time. And you just want to know, did I eat the rest of my damn sandwich?
What's fascinating is the first thing you said is the board. And so the audience, I want you guys to imagine, just like when you go to the airport and you walk through security and you look up and you see the departures and the arrivals and the times and what cities where they're going to, the ER has that board. What's on that departure board? What's on there? The time they arrived, diagnosis, tell me.
So a couple of things besides like their basic identifiers, their ESI level. So what's their severity index? What is the acuity of their condition? Then I'm looking at, is there any basic descriptor? Usually a couple of phrases like abdominal pain, back pain, seizure. Like it'll just be some kind of quick 1-word blurb about why they're there. Some other pieces that I pay attention to is anything done yet? Is labs back? Is imaging back? And then finally, nursing comments or whatever someone else adds, something like their PCP's number is this, or has a bone graft, or is an oncology patient of such and such, had an appendicitis with a recent appendectomy. Like those things kind of give me nonverbal cues to how I'm going to potentially approach that patient and what I could do to expedite their workup. The time frame is important, how many hours they've been there, how many hours we've been doing work for them.
Yeah, that's one of the things I always look at when the ER calls me in the ICU. I always look at how long the patient's been in the ER. So, man, the guy's been here for 6 hours. Anyway, but getting back to the initial ER, one of the things I'm really envious of in the emergency department is you guys really operate as a team in the ER, I think, more than anywhere else in the hospital.
It's essential, man.
And talk to me about the elements of the team that are involved in patients in the ER.
I think the emergency department is designed to function as close to a team as possible because there's so many gaps and so many things happening. That main thread of chaos can go in any direction if you do not operate as a well-oiled system. The teams that we have are everyone from the care provider, meaning like the physician or an APP, the nurse. You have sometimes learners or trainees, so residents or a fellow can also be in that team. Then there are like charge nurses, so head nurses who help oversee the logistics of the entire department. You also have your support staff, so these are techs, people who come by, do EKGs, who may help assist a patient to the bathroom or can place different devices on patients, even prepare you to do procedures, right?
Yeah.
Like set out your tools, lac trays, any type of plurivac. They know how to set these things up. Secretaries, so unit secretaries who can act as the switchboard and call all the consoles. When I'm trying to reach critical care at like 2 a.m, they're able to help get them on board. And then finally, there's like other hands. So sometimes staff members who all they do is talk to patients about their satisfaction, see what they can do, get them a blanket, a meal, a sandwich, some water. These things are all a part of the care team. And it's like as many eyes as possible to help see when a patient is on that verge of tipping into dangerous territory or crashing.
Yeah. I mean, it's really interesting going on to the ER because a great ER, to me, there's a lot of calm amongst the chaos that you see every single day.
That's it.
And I feel like the different team members in the emergency department are so well trained in doing what it is they are supposed to do that they make it really, really easy. Like I sometimes prefer to do my critical procedures in the emergency department because I know that tech that's down there knows exactly what I want and knows exactly the consequences of a procedure I'm doing and has the ready for what I need if there is a consequence or if there is sort of a complication or a natural thing that happens because you're doing serious things. I love being down there and doing that. It's one of the reasons why as an ICU physician, I like to float down there. I like to float, see what's up. I look at that board and I'm like, hey, is 26 coming to me? I see hypotension and shortness of breath and I'm peeking in the room and I'm like, patient doesn't look great.
You want to tell me about him now?
I don't want to get the call in 2 hours.
Yeah.
I want to go take care of it right now.
Right.
When you have these traumas, what goes through your mind? So somebody got shot or somebody got stabbed or somebody's in a motor vehicle collision.
Right.
Tell me about these traumas.
Well, I want to first hold space and say, like, all of these, you know, tragedies, they happen, and we have to, like, honestly take a second, realize, like, this is medicine to us, and it's about stabilization. Sometimes it's about intervening and intervention in general, but these are lives. There are people who have ecosystems around them that are getting impacted by this single event. And so I constantly think about that. But what's going on in our minds, it reminds me of that scene from The Departed where Leonardo DiCaprio is like across from the guy and he shows it that his hand is like flat. He's like, yeah, this is it. Like, I got steady hands. I don't shake. I'm unmovable. That is the energy that you come into that department with at the moment a trauma starts to be brought down or called in overhead. They're unpredictable. You can get a patient who the ambulance or the EMS team says one thing, and by the time they get to you, it's an entire different scenario.
Yeah.
They have worsened or declined in transit. Then there's also the need to intubate a patient. You can see somebody and be like, hey, there's no way we're going to get scans because this guy is all over the place. He's belligerent. He's drunk. Got a 4-centimeter gash across his face, eyeball popping out. We need to intubate this dude. Then there are those individuals who they're unresponsive upon arrival. Someone is doing compressions. You're continuing the compressions, going into, a traumatic arrest is one of the most vivid things that you'll ever see. You'll never forget it. And I think the common belief is that this stuff gives us an adrenaline rush and we're like, excited. Everybody in their sphincter is like this on asterisk, like the tightest that you could ever think of, because we are concerned that we'll make a misstep. And so those moments, while exciting to see, really require a heightened level of awareness. And you start to go back to your training. I'm still running A, B's, and C's. I'm going as formulaic and evidence-based as possible. I'm calling out things so everybody knows, open and closed communication. Like, these tenets of how we run traumas, they're there for a reason. And then the other part that's not really brought into this is you can't just be one service. It's you, it's the anesthesia team sometimes it's OB if it's like
dramatic delivery.
Right. Some type of delivery. It's a general surgery team, often a trauma surgery team. It can even be an orthopedics team, all in the same room at the same time. And you have to have a hive mind when you're approaching that patient.
Yeah. Not only that, is like when they're in the room and you're in the room and you're taking care of that patient acutely and you're trying to do everything you can to make sure this patient survives.
Right.
You also have to remember they've got family in the outdoor room,
that
right?
Part.
They've got mom, dad,
sometimes
grandma,
not even outdoor.
son. Right. Sometimes they're in the room.
Some they're right there.
Right. Right there in the room. And you have to sort of, again, you're the ER physician, but you have to sort of evaluate, treat, stabilize while also communicating with the family what's going on, what you're doing, why you're doing it these days. And it's just really, really chaotic, but your mind has to be really, really organized.
That's right.
And I commend you guys for that, because
thank you.
You guys do that very, very well. And oftentimes we forget that as the accepting providers after you've done all of that in half an hour, sometimes 2 or 3 hours, right? And so there's just certain respect that has to exist between the accepting team and the emergency room team.
Well, thank you. I selfishly, not even selfishly, almost a well-known fact is that ER docs, pulm crit docs, they go hand in hand. Like, there's like a continuum to us in a lot of senses, obviously from a management standpoint and the amount of learning that takes place on both sides. And so it's really refreshing to hear that. And it almost speaks against some of the microaggressions that you see bubble up among or in common circles in hospital systems. So I appreciate you saying that.
One of the things I never understood about hospitals is why the ER was so far away from the intensive care unit.
Yeah.
I think that is the dumbest thing I have ever seen in my entire life, because you can design.
It's poor design.
It's just a poor design.
We need IKEA furniture.
Because if a patient's crashing in the ER and you're you want to be able just to walk over and go see the patient and take care of them and go back and forth. I get it. There's a lot of people in the ER waiting room, but that's what architects are for, bro.
Right.
Like, design the hospital in such a way
for sure
the ER is next to the intensive care unit. The reason is, when you look in the ER, if you look at statistics, if you look at common symptoms, one of the things I read about maybe 10 years ago was The most common presenting symptom to a clinician in general was like cough. It was like 15%.
For sure.
When you look in the ER, respiratory issues, 10 to 15% of the patients presenting in the emergency room.
Depending on the season, even more.
Right. Have respiratory issues. Talk to me about what goes through your mind when you see patients like that.
I immediately snap to some of the darkest times and think about how the department itself became a hub of respiratory triage. You know, it's like, oh, this is mild, this is really severe, and how we consider intubating patients and how quickly we need to dispatch medications or therapies. It is something that is poorly understood by the average or common physician, but when it is at that volume, you start to learn the tricks of the trade. And for me, it's always like, how long before this person like craps out? I'm always looking at body language. I'm always thinking about like, what is their intubation history? Are they, mild persistent? Are they severe? Who's their home team if they have one? And a lot of our patients don't have these backgrounds with a pulmonologist. I mean, sometimes you have patients who are, on the fringes of society, have never been formally diagnosed with asthma, were told they had it as a kid, or somebody who's been smoking cigarettes for years and didn't believe in doctors until recently when they started coughing up blood. Also, the part that sometimes it's mixed pictures, right? Like where there's a CHF and a COPD exacerbation happening at the exact same time. And you have to figure out which one to attack first. Suffice it to say, respiratory illness and honestly viral illnesses exacerbating underlying respiratory conditions is something that we get a high level of exposure to, and we have to be very good at discerning who is going to be staying and who is going to go home.
What is a failing airway or scariest airway you've ever experienced?
Oh, shit. A pediatric airway or an adult airway?
Let's go with adult, then let's follow up with pediatric.
Cool. Adult airway, scariest one, upper GI bleed on blood thinners. I'm talking about I had 2 yank hours in the mouth and it still was not giving me a good sight of the airway. And so it just like looked like I'm talking about a crystal geyser just of blood coming up.
Yeah.
And I just think, one, whoever designed the bougie, we need to increase, whoever that family lineage is, we need to somehow funnel money towards them.
Right.
Bougies are incredible.
Yeah.
And so being able to, find tracheal rings with a bougie in literally like just putting something in almost like a vat of just red liquid.
Yeah.
And then going by touch was how we found the airway. And I don't care what you say. There's 1,000 articles about how you can do this safely and what tools and techniques. None of that shit matters when you're really sitting there. No one's thinking about, oh, remember when Tchaikovsky said that? No one gives a damn.
The airway, which is your trachea here, is in front of your GI tract. It's in front of your esophagus. We say anterior to esophagus. So if you're bleeding from your esophagus, so one of the common illnesses is called an esophageal varix, right? Mm-hmm. What they are really dilated veins in the esophagus secondary to liver cirrhosis. When your liver scars, that's what cirrhosis is, you get a backup of blood flow because your liver sees all the blood flow in your body. And that backup in the esophagus could lead to a dilated vein that pops and you're just bleeding profusely, which is what Italo was just describing. Mm-hmm. And when you're bleeding profusely and you're bleeding up, and it's in the mouth, in the back of the throat, you can't see anything when you're trying to get the airway. So yonkers are just these little machines that just suction. They're just suctioning all the blood out. And a bougie is a big, long tube. And what you want to do is you want to be able to see where that air bubble's popping through the blood, and you're placing that big, long tube just straight there. And then once you feel the cartilage of the tracheal rings, you could feel that little rigid, and you're like, ooh, I'm there. And you put the endotracheal tube over that in the airway.
Yeah, it's like a vacuum cleaner attachment and just trying to like touch that attachment piece blindly.
Yeah.
That's how it feels like.
That's when you're really, really, really scared because you have to get that airway, right?
Yeah.
And I remember a text message one day that I got. The ER had called me down to try to get this airway. They couldn't get it. The patient was crashing. And I literally, this is like my second or third year in practice, right? I'm in the ICU pretty much like 110 to 120 hours a week. Like I'm there all the time, right? I live there. I was really good
there
at one point, right?
Yeah.
And so I go downstairs, there's patients crashing, and I remember, give me bougie, and I said, give me a Mac 3 blade, because you couldn't use the video because the blood kept flashing.
Blood's gonna be on the video. The camera lens, you can't see nothing.
You can't see anything. And I remember just like taking that Mac 3 blade, opening up, seeing a bubble, putting the bougie in and intubating the patient. And I did this in like 35 seconds.
Yep.
And there was 27 people in this trauma room.
Mm-hmm.
And I walked in, intubated the patient, walked out, and I got this meme from one of the respiratory therapists, and it was the meme of this cat, and this cat was walking like this with the chest out, and on the top it said like, walk in, fuck shit up, walk out. Like that was like one of my proudest moments.
That you gotta feel like you a bad man,
right?
When you do that.
In that one, but I mean, like, the other aspect of this, you guys, is like, when you do that and a patient doesn't do well, or a patient dies naturally because of the injury that they came in with, having that emotional high of being successful with a certain procedure, but then the patient dies anyway.
Right.
And you have that emotional low.
Right.
How do you deal with that when you're talking with family members, when you're talking with a son or a daughter or a sister or a brother or a father or a mother?
Right.
How do you deal with that?
I try to impart upon them that the team acted exemplary, that we did everything, and that because of who that loved one is for them, that was a part of the consideration, is that we knew that this person was needed on this earth, and we wanted to give everything that we could to try to help as best as we can. But our efforts were not sufficient. And then I try to make sure that I give them time to have that recoil from the knowledge that their family member has now passed. Sometimes presence is important. I know a lot of physicians will say that stuff. They'll give them the, oh, well, I'm here if you need it. And then they'll like hand off quickly to whoever the bereavement person is in the department. I don't leave quickly. I'll stay there until they're ready for me to go. And we can get updates about patients while I'm in the room, but I just want to make sure that I'm present. The other thing is, you have to know kind of the background of that individual, so I try to get as much collateral information as I can before I get to that part of the conversation. If there's other details social workers have pulled or case managers have pulled or that's in the chart, I try to get all of that stuff so I can go in with an awareness of who this person is and who that means to the family. I remember, having a patient who was trying to do something like on the house, fell from a significant height, like a ladder, and basically fractured his neck, had a significant brain bleed, herniated, and had got intubated. And then we still lost him because he just essentially bled.
Yeah, cerebral edema. And, yeah.
And the son was a student, understood medicine, and had to help kind of interpret for his family what this meant. And so imagine being a medical student and getting this information, and then being the one filter piece to your family that partially doesn't speak full English and also doesn't have the educational capacity to understand the efforts that were done and how this is now no longer going to require, we can't bring him back.
Yeah.
And so thinking about moments like that in the position of each one of the people in the room is a part of the process.
Yeah. It's hard when you're talking to family members, as you just said, because sometimes these patients look like normal,
right?
But they have these internal injuries.
Yeah.
And you sort of have to show them the internal injuries, but they have no baseline as to what normal is supposed to look like inside.
No concept of it.
And it gets very, very difficult when things happen like that. People fall and have, a brain bleed,
right.
Or people, fracture and rupture a certain part of their vasculature that leads to death.
Yep.
It's very, very difficult to deal with that. And I hear you and I respect you. Honest question though, you seem to have sort of this insight that I would say most doctors in general may not have or may not be willing to do because of the way that they cope with things.
Sure.
Do you ever notice when you're working, your colleague maybe not doing that and you just kind of stepping in to take some time and do the explaining and be there for the family?
All the time. I mean, I'm not free from that. I remember during residency having moments where I couldn't go tell, a grandmother that her grandbaby is dead. 12-year-old asthma patient came in, had a severe asthma attack. We couldn't get the tube in time. baby died. And I was like, I can't tell her this. And I watched my attending be like, it's okay, I got it. And then remembering that feeling. And so now I have residents where it hits so close to home that I'm like, I got you. You don't have to go into this room. Or even women, for example, who have lost children, we just telling them that I'm sorry, on the ultrasound, it's no heart activity, no cardiac activity on the fetal monitor. That can be traumatic to someone who is maybe trying to conceive or is actively pregnant. And so I always make sure that I talk to our residents or trainees, like, hey, are you cool with this? Because I can easily go in there and do this. And it's no knock on where you're at. I just realized that we're humans. And some of this information, as much as you want to, detach from it when you hang up your white coat or get in your car and close that door and turn on Project Pat, whatever it is that you drive home to, that's just me. But you can't detach enough. And sometimes those stories and memories stick with you. And so it's okay if you want one less memory and I can distribute that over into my bank or vice versa.
Yeah, you want just enough physicians to understand how to deliver this type of information that needs to be delivered.
Yeah.
But at the same time, like when you're in medical school, resident, fellow, whatever, you can read about heart failure. You can learn about heart failure. You can learn about the airway. You can learn how to intubate. You can read that in 30 minutes. You could do that.
Yeah.
But learning how to talk to someone about the loss of a loved one and being able to mentally deal with that emotional blowback that is inevitably going to come is something that only experience will get you through.
Truth.
And you have to go through that experience.
There's no amount of role playing. I remember they have you do that, like, let's go through and simulate how you're going to deliver bad news. Let's role play and follow these prompts. None of that matters in the moment. And it's cool when you think about it and you're trying it on, but that fit is not a one size fits all. And the more you say it, you have to fight back being desensitized from it because compassion fatigue is real. And many physicians walk around the department like in a hurt locker, as if, everything can just be contained inside and they don't have adequate ways of kind of releasing that, working through it, and honestly processing. And so realistically, these roles, these jobs that we do come with significant gravity, and there's got to be counterbalances for all of that.
Not to transition to this, but I think it's a nice transition. When I look at the HBO show, The Pit, I watch it and I'm like, okay, I can see that. I can see that happening. The one thing that I think is absolutely, positively not real and completely fake, honestly, is the emotional conclusions between the physicians, the conversations that they have with one another. I'm not saying that these conversations don't need to happen and we don't think about it in our head.
Right.
I think they do need to happen.
Sure.
And I think we do think about these things in our head. But the amount of time that it takes to go through that is not real. Right. People on the roof talking about their emotional roller coaster that they go through. Like, for me, I'm like, this is a great idea. I love it. And that's what attracts us to the show.
Sure.
But I do think that is a bit exaggerated.
No, I catch a lot of heat on YouTube from when I cover this stuff. And I'm like, hey, really love the fact that this is movie magic. And then people in the comments just eat me up because I'm like, no, in real life, I don't go to the roof of the hospital and peer off into the distance and say to myself like, I wish we could have saved him.
Yeah.
I've gone to the ambulance bay or EMS bay and shed some tears or cursed out, but I've never sat inside of the EMS truck and just thought through my life decisions. But I'm sure that that's happened.
Yeah.
Realistically, you still got that patient in 12 who is going ape shit. You still have like 4 or 5 other really critical patients that are in the department. And so you have to really compartmentalize things. And it's hard.
And I look at the ER and ER exposure management, what you guys do today is a lot different than what it was 20 or 30 years ago.
Big facts.
Because in the United States, a lot of people have chronic conditions, right? And in the ER, in 2022, there's 155 million ED visits, 43 visits per 100 people.
Right.
11.5% of those resulted in a hospital admission. But a lot of these people, like 25%, had like a chronic illness. So I feel like you guys are doing a lot of education
Sure.
and a lot of teaching on chronic illnesses.
Right.
But are there ER physicians that feel like that's not my responsibility? I'm here to take care of acute problems, fix them, and go back.
I think that there is a philosophy that has developed where it's like we want to get to this space in emergency medicine where the things that we are skilled at, we're constantly doing at a high rate. And then the primary care components, we're outsourcing to the physicians who are designed to kind of manage those things. I don't sit in that verge. I do think that it's inevitable for us to get someone whose chronic disease has gone on so far or in extremis to the point where they need to be acutely managed. And I think that the struggle with that comes from emergency physicians constantly fighting for territory. We believe that we're tacticians. The things that we do are done at a high level, and you lose some of the credibility among other professions, specifically like surgical subspecialties, if all you're doing is quote unquote like clinic medicine inside of the emergency department. Now, on the other side of things, the primary care workforce is drastically undersourced, right? They don't have enough primary docs. And so there's invariably going to be a patient who comes into the department who is not being compliant with medications, or their dose is not enough, which is why they're in an exacerbation, or they're not on the right meds at all. And so you have to be a connoisseur of all of these things and be able to manage them or co-manage them effectively.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question, and it's an interesting one. What's one question I should always ask when getting a new prescription? First of all, please understand that any question you ask is extremely important, so ask away. But if there was one question, here's the question that I would ask. What should I expect, and how will I know if this is working? That tells you the timeline, the goal, and the warning signs all at once. If you know what success looks like, you're far more likely to use that medication both correctly and safely. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. What are the 3 chronic illnesses that you wish you learned more about to be able to help the patients you see most?
Number one is going to be diabetes. I think diabetes, even the idea of the medications, the approaches, the decisions around which medications, these updates we're not getting as emergency physicians. We're kind of learning them from our primary care colleagues.
Right.
And every now and then we get like a batch of information, like an update, but we don't understand like which one should be tailored to this individual and why all the time. So that's number one.
And when you guys look at diabetes, just real quick, elevated blood sugar as a result of either reduced sensitivity to insulin, which takes blood sugar and puts it in the cell, or a lack of production of insulin from the pancreas, right? And that's kind of autoimmune diabetes.
Facts.
The problem with it will lead to an increased rate of cardiovascular disease, right? And so when you have cardiovascular disease, right, you're going to have heart attacks, which people can die from. It leads to a lot of different issues. And so when you're not able to know how to manage those blood sugars as effectively as you possibly can, or educate your patients as effectively as you possibly can, this has a huge impact on society and what you see on a daily basis. I'm not surprised by him saying, yeah, I wish I understood the delivery of some of these medicines more for diabetes. What's number 2?
Coronary artery disease is something that a high percentage of the patients that I see come in with. Yeah. And I think we understand the severe spectrum of coronary artery disease. We understand how to diagnose strokes. We're really good at looking at EKGs and being like, hey, this person has signs of ischemia. We know what to do once that happens. We even understand how to check for like angina in all the different forms of it. What we don't understand, honestly, is like that person who's on the cusp and what can be done from a medication standpoint versus what types of modalities and when those modalities should be done. Like, is it safe to send this patient home who might need an echo, who should get a coronary CT? Like, what is the threshold to do that, and what is the time frame for the management? And I say that because, again, these conditions can progress very rapidly for some individuals based upon where they're at on that spectrum. And also the medications that our cardiologists are using, their insight in why they use them and what the updates are and whether or not this type of a platelet blocker or thinner or whatever is effective. Like, I think that that insight is something we don't have at, ready recall every time.
Coronary artery disease, again, is just blockages of the three major pipes that give your heart nutrition. So when you block those pipes, your heart muscle dies off, can't pump as well, can't pump blood as well. You get lack of perfusion to the brain, to the heart itself, to the rest of the body, and that can cause issues. That's another one. And again, I didn't even think about that one, but God, that makes perfect sense. Like, what molecule should we use when? What's number 3?
Number 3 would be the spectrum of obstructive and restrictive lung conditions. I am at an institution where we have a ton of research that goes into this. So I benefit from having people who know this, but in a freestanding ER and some of the, more private equity run places, they don't have that type of access to like a pulmonologist or even someone who like ILD, for example, something I see all the time. And these patients can come in really sick and you're not knowing like what medications they should be on. Sometimes is a problem. I think also in that same bag is your patients with like pulmonary hypertension who could also have some sort of respiratory component because of that. So I would say obstructive and restrictive lung conditions in general.
Yeah, one of the problems with pulmonary hypertension is nobody has owned it. Pulmonary doesn't really want to own it. Cardiology doesn't really want to own it. It's very strange. It's a very, right? And so that's why it can be difficult to deal with. And in terms of the education that you're receiving, that even I'm receiving, it's kind of fragmented.
It is.
Obstructive lung disease are diseases that take place as a result of your inability to breathe air out. So we're talking asthma, chronic obstructive pulmonary disease, COPD. Those are obstructive lung diseases. Usually they affect your pipes, right? And then you have restrictive lung diseases, so your lungs feel small, like a rubber band's around them. That's interstitial lung disease, pulmonary fibrosis. So you've got inflammation and scarring within your lung. And typically what will happen in an ER, and I'm not saying it happens in his, is the ER patient will come with shortness of breath, and 9 times out of 10 they'll say, oh, it's just COPD. But it's probably not, right? You get a CT scan, you see inflammation, you don't really see obstruction. If you were to look at their old pulmonary function testing, I want you to talk about sort of the outreach, the prevention, the community engagement that you've been involved in as it pertains to that.
Super passionate about extending beyond the walls of the hospital, right? When I think about the patients that I engage with, often they are on the fringes of society. They are vulnerable patients, and they often don't have the luxury of being able to get wraparound care or follow-up care. And so that one touch point becomes so critical. You may be able to change that person's life just by the decisions you make in that interaction or right before discharge. But outside of the hospital is another ball game, right? Community members respond in a certain way to clinicians, right? You've experienced this. You go back to, Sacramento or anywhere that you've lived, people are like, I know him, and they're happy to see you. And you carry a certain amount of social capital with any type of, surrounding that you go into. That means that you can make good messaging for them and go and work with them to help understand and identify their biggest health concerns. So when I'm talking to patients in barbershops or going to community centers or going to city council meetings and I'm taking inventory of their health issues, it's not something that I'm hearing from a book or from a podcast on, medicine. I'm getting this directly from the source.
Yeah.
And so I can hear the struggles that they're having with getting follow-up appointments. I can hear about the fact that the rising cost of healthcare is causing people to just opt out of caring altogether. I understand that they've got competing interests like paying for groceries, childcare, transportation, understanding whether or not they can help fund somebody's college because they're working 2 jobs at baseline already and still don't have enough to make ends meet. All of these factors change the way someone experiences the health ecosystem or the healthcare ecosystem.
Yeah.
So what I look at with social emergency medicine is what are these, threads that we can tug at to try to address core problems and hopefully keep them from being in extremis or coming to the emergency department altogether. And if they do come, what are the services that we can offer that are more robust than just putting a Band-Aid on something, suturing something up, putting a tube in somebody, or, any of the therapeutic approaches that we have. There's sometimes a little bit more of a human touch that's required.
You taught me the value of community in places like the barbershop.
Yep.
Like when we go to the barbershop, and sometimes the barber has to come to us, we get it. But when we go to the barbershop, it is an opportunity to engage in health discussions.
Facts.
And you've taken this to the ultimate extreme, to the pinnacle, right? With barbershop medicine. Tell me what started barbershop medicine, why you started it, and what you're getting from it, and what the barbershop patrons are getting from it.
Since maybe the late 70s, early 80s, we've seen the relationship between physicians who come from, communities that have struggled, going back to those communities, trying to build interventions and programs that work. Everything from faith-based organizations have been involved. And then someone had the bright idea to start saying, let's go back to the barbershops where we know the relationship between the patron and the barber is like rock solid, ironclad. You'll see your barber. How many times do you see a barber? A month?
Well, yeah, 4 to 5. 6.
4 to 5 times,
yeah.
Right? Most people don't see a doctor 4 to 5 times a year,
right?
Let alone maybe even 4 to 5 times in their lifetime.
Right.
And to know that the average, for example, Black guy is going to get his hair cut every 2 weeks, that's a time frame that is like reliable. You can depend on it. You can count on it. And so weaving healthcare or health initiatives into something like that creates the opportunity for you to capture some of those, people who are, again, not getting the adequate health service that they need. What is also really special about that space is that people are more vulnerable. You see a relationship built, that trust factors established, and you can get some of the best insight about someone's health while they're sitting in a barbershop chair. They'll tell you about their mental health. They'll tell you about what they're eating. They'll talk about how their relationships are going with their family members and loved ones. They'll tell you whether or not they've gotten screened for something, a colonoscopy being one of the common things that we talk about in the barbershop. They'll talk about sexual health, talk about drug use. They'll talk about all of those things in one space. And so leveraging that and trying to meet them where they are, not being judgmental, but also coming with real support services and actual health knowledge is of high value to the patron and to the community.
A little less serious, and I'm going to get into some
short
questions, right? So
I've been waiting all day for this.
Yeah, quick answers, no overthinking.
All right, done.
Ready?
Yeah.
What's the most ridiculous injury that made you laugh later?
Pomegranate juice bottle stuck inside the rectum as a foreign object. I'm looking at the x-ray. I'm saying, sir, what is this? And he just saying, palm. I'm like, palm? He said, palm bottle. I was like, oh.
So you had to go in there and retrieve it? Or the surgeon have to retrieve it?
Yeah. Here's the thing. I thought I was retrieving it. Once we get to it, my thought was, I'm going to use some forceps to unscrew the cap. I'm going to pierce through the seal, let the juice run out, float a Foley through the mouth of that palm bottle, inflate it, and then try to use it as traction to pull it gradually out as we lubricate the sides. As soon as I get the cap off, no seal. So I'm like, all right, cool. It's just paper, and then rocks start to come out. I said, sir, what's in this? He said, gravel. He done turned it into a paperweight. And so now it's gravel and glass inside his rectum. And so, yeah, he went to the OR at that point.
You were like, I'm done.
I said, dog, you could have told me in the beginning. You could have told me. You rode all the way here in the car.
Did you ask him
with your spouse?
Did you ask him why he
hit
did
every pothole? No discomfort. I said, you are the strongest person I've ever seen, sir.
Is that why he went to the ER?
That is why.
Who put it there?
It's a mystery.
All right. How do you decompress after a tough shift like that?
A couple ways. I mentioned earlier Project Pat, but I spend the 35, 40-minute drive home usually listening to new music, and I try to really feel whatever is coming on. Like, as long as I am safe to drive, I drive home. I think about the cases. I go through and like, oh, that was a tough case, or I learned something from that, or man, I could have done better at those things. So I spend that 1 hour time frame, but as soon as I cross the threshold of the door to my place, I'm done with it.
You're done.
I'm done with it. I go in there, I'm like, what's in this refrigerator? I go, maybe, let's knock off these shoes, get to the gym.
Yeah.
Who's playing tonight? Let me see what game is on. I'm done with it as soon as I cross through the threshold of the door.
What's the best and worst part about working in the ED?
Best part are the stories, the narratives. These patients imprint their lives on you, and you have some of the best, bar stories, some of the best stories of hope, some of the best stories that I use to change the minds of politicians, to get funds for different programs, come from me talking about what I've seen in the department. The worst part, honestly, is the tough days. And tough days aren't always days where you lose a patient. Sometimes it's the day where you couldn't help that person and they seem like you broke something inside of them. Sometimes you have to do medication restraints on a patient, or you have to use medications on somebody. You're like, I know you have a mental health condition and that you need services, but right now this is the best we can do to get you to where I can actually treat you. And they look at you sometimes with a face of despair and hopelessness. Sometimes it's children, like seeing children in extremely vulnerable positions. I remember one of the toughest things I've ever done, the hardest case I've ever had, was doing a rape kit on a 5-year-old. And so that to me is something I can never, ever walk away from. And trying to pray at the same time that this experience does not scar that child for life, while I know it scarred me, was just heartbreaking.
What's a rape kit?
In some places, and most times they have nurses or special teams that can be dispatched in some areas where they collect evidence, like physical specimen, everything from secretions to cells of the area where sexual contact has occurred, the unwanted sexual contact has occurred. And it allows you to get high-level forensics testing on these things, as well as do the testing to make sure that there's not a medical risk. So all of your sexually transmitted infections can also be essentially assessed at the same time. You also have to write and describe the physical damage, because if there's going to ever be some legal action followed, your report will be taken into account. And so having that conversation in a room with a 5-year-old, by myself with a nurse, like a chaperone present, but not her parent, and then trying to navigate that is just, it's something I wouldn't wish on my worst enemy.
Did the person who did the sexual assault bring him into the ER?
They did not, but they were related to that person. And I just remember it's multiple layers to it, right? So obviously this kid is like, I don't know why this was happening to me. And you're trying to comfort the child, but then the parent is now, one, ready to send the war dogs after this individual, but also wondering what they've done wrong. And so now you've got 2 patients, and people who are interacting with this are all going through their own traumas. So the chaperone or the nurse that's a part of this, who might have a child, is thinking about this. The person who wrote in the triage note what happened, the persons in the lab who are taking the specimen are like, wow, this is a specimen of a 5-year-old. All of this stuff is rippling outward. And you have to constantly stay centered on, all right, this is a 5-year-old who at some point is going to grow into an adult and have to deal with the trauma that when I was 5, someone was molesting me or sexually assaulting me. That type of, in your lap, you just picked up the next patient.
Yeah.
You didn't realize this is what it was.
Yeah.
So that's why I said your worst days aren't always days where you lose a patient.
Yeah.
It can be a variety of things.
Have you ever disagreed with a colleague on how to treat a patient, and what happened?
Yeah. How much time we got left? Yes. Every day. I think the disagreement is healthy, though. This is something I learned from folks who work in tech and engineering space. They actually seek the friction. They want to disagree with somebody, because on the other side of that is a breakthrough, and they're learning another tool. Mm-hmm. And so I seek that. And it's not that I feel like I know everything, because I for damn sure don't have this, infinite level of knowledge. I'm not walking around up to date. That's not me. But I know that I've seen a high volume of patients and I know what I've seen work. And so if there's something that you can convince me of that works and that's evidence-based, and then it has like good evidence, not just kind of some evidence. And then finally, it depends on the circumstances of the patient. Is this somebody who I'm willing to take that risk on? Like, if you can do that, great. If you can't, my name is signed in this chart.
Yeah.
So we're going to do it this way.
Yeah.
And I'll sit with whatever feelings you have around my decision to do that. And I can actually explore it after we do this with you. That's what I tell them. Like, look, if we still feel raw about it, let's talk about it in a little bit. Other disagreements, things that come to my mind right off the bat. Sometimes, like, simple disagreements like this person shouldn't be admitted, this person should be admitted.
Mm-hmm.
And sometimes the reason for admission is not a medical one.
Yeah.
And that can be dicey when you're talking about a finite number of beds or a finite number of man hours to see patients and do things, especially if it's not going to move the needle much. So in those situations, sometimes I will concede and be like, all right, you're right. Let's just discharge this patient. Then there are really tough disagreements. Like, I see something they don't see. They're telling me that the patient is stable. They're looking at this information from a screen. I'm like, no, I can physically see the patient. You need to bring your ass in here now and come do this.
What's the craziest thing that you have ever seen in your emergency department?
One of the first crazies that comes to my mind is the bypass, AMS bypass, everybody scoop and bring in. So I did residency in the Bronx where you see everything from stab wounds, $150 to the face, shotgun, machete slice to the back, all of that stuff in one night. This patient who was brought in by his partner, it was a police officer. They were trying to stop a bank robbery, and the persons who were robbing the bank shot back and basically shot him in the head. And they brought the patient, the partner, he's a cop. He doesn't have to ask permission to pull up to a hospital. He pulled up, scooped his partner out, and just sat him on a gurney and was like, help. And we look at him, we're like, yo, his brain matter.
He's dead.
Right. But it's an officer, so you do what you can. Another crazy case that comes to mind, meth lab explosion. 5 different things happening at the same time, and they're all brought in one after another. You start to see the department shift. So this is essentially a mass casualty event. I've been a part of 3 mass casualty events, which is crazy.
At Stanford?
Nah, one was in Gilroy.
Oh.
That was one of my first years at Stanford. But everything, like I said, meth lab explosion is considered a mass casualty event. But I'm talking about like school bus, flip over, hit a bunch of cars. I'm talking about active shooter in a hospital over, everything. Multiple times have I experienced this. With that said, the meth lab explosion, first person comes in from a heart attack, trying to ascend the stairs. He's a firefighter trying to ascend the stairs to get to the fire to try to save somebody, has a heart attack. Second person that comes in actually has the injury from the fire. So like
Burns.
Smoke inhalation, burns, things like that. Third person that comes in, amputation. Driving a rig, has his arm out the window trying to get to the fire. While he pivots a corner, like spins a little too much, arm gets caught on a rebar, like a little wire, rips wide open. Jeez. Fourth, head strike. Somebody trying to save themselves from the fire, jumps out a window, bow. Right, so you're dealing with that.
Yeah.
And then the fifth person is just kind of like minor. And so you're getting all of these at the same time. And you have to like divide resources appropriately, figure out who's going to do what. And that day was my birthday.
Ooh.
So I no longer work on my birthday because a meth lab exploded. And so
that's also 5 families that you got to talk.
5 families, 5 different tiers of people, everything from, a community member to service workers to whomever, like older individuals, young individuals, all in the same space. And so it's a lot of sophistication in terms of how you approach it, what you do in the aftercare for both the patients and for their family members and yourself.
What's your ER theme song?
I never thought about that. I mean, ooh. Immediately I think about Who Run It by 3 6 Mafia. It is, to me, a fight song.
Uh-huh.
And when you walk into a department, you have to have a certain chip on your shoulder. It is clarity, but also like, this shift is not going to kick my ass today. It's you versus the shift. It's not you versus a service. It's not you versus a consultant, not you versus a patient, not you versus a mad person, a family member. It's you versus the institution of the shift, which is, it's unpredictable. It's hairy. Something that is going to happen that I can't control. I am going to get behind and start drowning at some point, but I'm going to fight like hell to keep my eyes and my nose above the water level.
What advice would you give to med students about the emergency department, thinking about that?
Come through. Come experience it. I think it'll give you a greater appreciation for medicine done at a high level with good evidence, and also teach you about versatility, specifically like how to have good hands and a good brain, how to develop communication skills and leadership skills, like all of these different soft and hard skill combinations. You'll get exposed to it in the first day. And then lastly, I would tell that medical student, like, what kind of life do you want to have? Like, do you want to see your family? Do you want to have money and be able to experience what it's like to have those resources? Do you want to have impact? Do you want to potentially be someone who could shift policy? Do you want to be closer to the people than ever before? Like, you have all those opportunities, and you can build a life out of working in emergency medicine that's on your terms for the most part. You may miss a few brunches, some holidays. You're not going to make every basketball game, every birthday, but you'll be spending it with people who needed you. And that's sometimes rewarding.
What's the best advice you've ever received as a doctor?
You're not God. You are not God. You can't make something that was already destined to happen different. You can only act and continue to do what you've been trained and taught. And so I think that that's like a personal check. And I think it works on two ways, like realizing your limitations, but also checking yourself, saying like, no matter how dope of a thing you did, you don't run it all. You will make mistakes.
Yeah. Is the ER like it's portrayed on TV?
Yes and no. I think it's important to distinguish the pace of the emergency department on most of the medical dramas is a little exaggerated, but for good reason. We want it to feel real to you. And so you have to embellish the cases and make all of those cases seem like they're all happening at the same time. What is also very real is the medicine that you see done, like the nuance, the cases. These are real cases that people are talking about. It is actually one of the best ways to learn about medicine is watching emergency medicine shows, because they're going to tell you like all the things we considered. All the tools that you're seeing there are tools we really use. Like, people are pulling out ultrasound probes to look at these things. We do that every shift, right? That's almost an emergency medicine and a poem crit thing. It's like, yo, give me the probe.
Yeah.
Right. I need that. It's bedside.
It's better than a stethoscope.
Right. What's not real is when you're starting to see the interactions kind of like romanticized a little bit, or you feel that the show is doing something more provocative. I think that you have to be discerning there, because we're always going to respect patient safety, patient comfort. We try our best to find spaces for patients, and that gets lost in the nuance. People think that you walk into an emergency department and it looks like a war zone all the time. It doesn't always start off as a war zone. And when it does get to that point, just know that that's not the department's fault. That is a systemic problem. And that's something that can't be solved in that 12-hour, 9-hour, 8-hour shift.
Look, I mean, what you guys heard is what the emergency department is really all about. Medicine, humanity, social context. I mean, Italo, sum it up for us.
Emergency medicine is acute problem management and triage. We have the ability to see things that a lot of physicians don't, meaning the convergence of social problems and health issues, and have to sort through it in sometimes very narrow time windows. We want to figure out if this person is healthy enough to go home, if they're so sick they need to be admitted, or if they need a little bit more time to cook and settle out. And then finally, in those moments that are most tense, we get paid to think and to act. with a high level of skill, proficiency, and to always think about the patient and keep them first.
At the end of our episodes, we usually do what's called a positive pulse.
Yes.
Positive story, something you were involved in, maybe something you're not involved in that you just saw. Give us a positive pulse.
Positive pulse would be my father, man. If you have ever met a black man who was like a product of the 70s, they move a certain way, they still believe in Shaft. He wears leather coats every day. No diss to whatever kind of material this is. I'm just saying it is a unk status when you wear leather on hot and cold days. My father didn't trust docs at all. I mean, growing up, and I'm like, Dad, I'm your son. I'm a doctor.
Mm-hmm.
How you not gonna trust doctors? More recently, he has been having open conversations with me about his health, and he is actively seeing a doctor. I went with him to his health visits, and he's starting to like use the language and almost look forward to it. You got to realize my father is like a 75-year-old guy who lived through multiple phases of healthcare systems. It's from the projects in Saginaw, Michigan. He only goes into hospitals when someone is dying, and has had to have fights and arguments with healthcare providers, and almost feels like the system has done him wrong. But I am encouraged, and when I see somebody who was so rigid against healthcare change their mind and feel like the trust is being restored. So the work that we're doing as healthcare workers and folks in the medicine space is reaching some of the furrows of society, people who feel like they were never going to be building relationships with physicians.
So interesting to hear you say that. I like to get to know people, you know that.
Yeah.
And when I think about everything that you have done, healthcare disparities, curriculum, speaking on social justice and medicine, right? Developing programs to engage in our community about understanding health and how to be healthy. What's funny to me is hearing you say that right now tells me and helps me understand you did all of this for your father.
I think that that's something I have to acknowledge, is like, he's the guy, the hardest patient. He's the toughest one. And if I can get through to him, all this other stuff is light work.
That's a good way to end it.
Yeah.
Where can we find you, Dr. Brown?
First of all, I hope you don't find me in the Stanford Emergency Department, because it may not be the day that you're looking for.
Yeah.
But no, I am at a few different places. On Instagram, I'm at GR8Vision. And I think on every other platform, just Italo Brown, MD. Check me out on YouTube. I do a series called Med versus Movie, where I break down real life injuries from the lens of a camera. So all of your cinematography. I love movies. I love talking about movie-related injuries. Check me out.
Thanks for watching and listening to The Health Exchange. We're on Instagram at The Health Exchange Podcast. We're on YouTube, Apple, Spotify. Get us wherever you get your podcasts. We see you every Thursday at 6 a.m. Pacific, 9 a.m. Eastern. We'll see you next Thursday. Thanks again.